See, what I'm going to do is I'm not going to do this. I'll jump in formally as people get here. But I'll just start with some background that you guys know, but what I want to, I think you'll know, but I mean, this is at the root of, in terms of professionally, this topic resides at the root of the whole UTOK tree, in the sense that what happens to me as I learn to become a psychotherapist is what ultimately is going to sort of wake me up to a set of problems. And then that's going to back me into, well, wait a minute, psychotherapy has this problem of value. It's also has this problem of fact, and not to separate those are, but there is a science problem that should be grounding this at a conceptual level, not just an empirical level. There should be a science that grounds the science of psychology rather than all these schools of thought. Could that ground? And then that I fell into the problem of psychology, and then fell into evolutionary psych, caught an insight on justification, which then really split the culture person plane away from then what would become the animal mind plane and the life organism, matter object, and ultimately energy information structure. And then, of course, got obsessed with that. I, for 3 or 4 years, was just doing physics. A lot of what I was studying conceptually, and I never did the math. So I was always an amateur, but I got pretty good at tracking the various arguments in physics and understanding general relativity and whatnot. And then evolutionary psych, and neuroscience, and then had in behavioral science. Actually, learning Skinner was unbelievably crucial for me, and then framed what I could see through the tree of knowledge. And then I came back to psychotherapy. So that took me all the way up to 2011. And in 2011, I came back to psychotherapy and built some of the other key insights that are going to be part of UTOK: character adaptation systems, the wheel of development, nested model, and COM-MO in particular. And that's where I thought I was going to be. And then weird things happen. Ultimately, the garden and this coin and the whole unified theory emerges. But as Jack knows and as Andre knows, we were in the process of really trying to develop a unified vision. And in some ways, at least in relationship to that, the timing got... I wish I could reconfigure the timing, of where we were and where CEPI was, and where everything happened. But from 2011, 2016, we were really focused on this. It sort of dissipates, but then the wheels unfold so that, and especially thanks to Andre's leadership, we get unification as a particular pathway, of course. And it's because and then I get wrote back in and have an opportunity after Barbara Ingram can't be president. I get president of CEPI, and I get focused on this, and I get returned to this whole issue about, well, what is the center of psychotherapy? And that's what and then I'll work with Marcia. She's launching a thing in Brazil called Nexus, which is a movement to try to bring the ideas of integrative psychotherapy to Nexus. And then it enabled me sort of to return to this whole issue about, well, what would be a grounding place for psychotherapy? Like, where should psychotherapy start, and how should it be organized for people to be informed about? And that's what I would then have developed with Marcia, or at least a doorway into that, called the Common Core. Okay, so I've written a 60-page paper on this that I think is impressed with JPI, or I got very favorable reviews. I'm optimistic. And Andre, thank you so much for your leadership on that. It's really exciting. So this session is exploring the Common Core, getting critique, elaboration, etc. So I'm going to spend the next 5 minutes really delineating what the Common Core is. Folks already know more or less what it is that I've read, and then the folks are going to be commentating. Well, Steven, and then Dre, and then Jack will be offer a comment, and then we'll dialogue. Okay. So fundamentally, what is the Common Core? Well, the Common Core builds off of the concept of common factors. Common factors, this was actually mentioned by John, is the idea when we look at the psychotherapies and we horse race them, the bona fide treatments tend to get very similar outcomes. You can nitpick this argument and say, well, here you get something and here you get something. I think that if you take the overall view, the bona fide treatments for, I'll say, the internalizing neurotic conditions, That's anxiety, depression, low self-esteem, the standard presentation. You horse race them and you control, you get very similar outcomes in relation. I think that's a robust and generalizable finding. And so the issue then is, well, what are the healing factors? Jerome Frank is I would say he's the pinnacle of the common factor argument. And more recently, Bruce Wampalt built off of Jerome Frank and empirically analyzed key elements and generated what he called the contextual model. I'll call it the contextual process model. Okay. The contextual process model is this argument puts common factors in relationship to a medical model, whereby a medical model, I don't mean like, medical treatments. I mean, the key to treatment in psychotherapy is diagnosing a problem and having a specific intervention that fixes it because it's got the correct mechanisms of change that diagnose a specific problem. That's the idea is that, hey, medicine fixes particular problems with specific interventions. That's one model for psychotherapy. The contextual process model says, the actual diagnosis and the actual intervention, while maybe relevant, is actually hides much more general psychosocial processes. And we can, if these processes are met, the language that you use and how you diagnose becomes much less relevant, or there's a huge amount of plurality that you can utilize. You can talk about your repressed desires. You can talk about your beliefs. You can talk about your habits. You can talk about your attachment system. But if you meet these criteria, actually, these are the elements that we really show outcome. They're the ingredients of the contextual process of healing. Now, what are they? They are the general societal structures that legitimize the healer, which means that you have to have a license, you have to go through a particular process, you put stuff on the wall, and at some level you have some languaging expertise. That's so that you have trust and expertise so that somebody sees you as somebody that's appropriate in this role. That's the first contextual. Then you enter into a relationship, and Bruce Wampalt, building off of Jerome Frank, said that there are three basic lines and processes that we can identify. One is the relationship, okay? Relationship quality, that's what I'll call it. You can belonging, etc. Quality, the real relationship. There are different angles on this, but hey, do you feel seen, known, and valued? I'm going to use a UTOK frame. Do you feel seen, known, and valued in the appropriate way? And do you become important to that person in the appropriate way? And to the extent that you meet that role and they can say, yeah, I really trust my therapist, I think they really respect me or honor me and somehow, and I appreciate what they're doing for me. Okay. There's good relationship flow. I like them. I think they're competent. That's really key. Okay. Second, do this therapist and the therapy process help you understand your problem, the situation you're in, and who you are, so that it makes sense what's happened to you and gives you a sense of sort of understanding, insight, expectation that things could be different. Okay, so it's both understanding with hope. That's the second key ingredient. And then finally, what are the ritual healing elements that you motivate people toward? Okay, so it's the relationship, the shared understanding into expectations for healing and motivation to do that, and a willingness to enact that in a way that makes sense and is hopeful. You can add a feature to this if you want, and it's just feedback to that. Like, do you check the outcomes? Outcome-informed care is a kind of generalized therapy that really says, hey, you want to check that? I'll just weave that into the last one, like I'm engaged and checking. So here are the domains. I argue, Bruce Wampalt says, hey, here's a meta theory. I don't think that's the right word of meta theory. It's not a meta theory. It's a conceptual model that he's contrasting. It's a contextual model versus the medical model. There's no theory that he offers. He says some things about, we're evolved primates, so we care about relationship. But I would argue UTOK is a meta theory, okay? And what UTOK can do is UTOK's big picture view says, well, how do we contextualize legitimizing structures in a society and why are they valuable? That's the first point. UTOK says lots of things about the kind of relationship, in particular issues of relational value. UTOK gives us frameworks for thinking about how we build understanding. And UTOK has a general principle and process for the context of therapy that enables maladaptive cycles to be reversed. That's called COMMO. And so that's what we delineated. Oh, if folks can come in and mute, that would be good. I'll mute. So that's the basic argument. I want these guys to have plenty of time, so I'm going to end it there. I'll be happy to send anybody the paper, but it's essentially, there's a contextual model. UTOK is a meta theory for that model. And that's where we should start. The last thing I'll say, and I'll wrap up, is we should have this as the general control condition for psychotherapy. And it doesn't say we could never develop interventions or that we can't get much better at mechanisms of change. That's, to me, sort of the next step after the contextual process stuff is in place. And that's really how we would grow a competent, cumulative science and practice of psychotherapy. That's on the line. So that's my summary of it. I'm going to hand it.
I want to interrupt for a second.
Yeah.
Could you spend like 2 or 3 minutes on EMPs and COMO? Because I think that's an important part of your paper where you extend your summary of Wampolt's contextual.
Yes. Spend a few minutes about COMMO, did you say? And
EMPs
triple negative neurotic loops?
COMO, EMPs,
Yeah, okay.
entrenched maladaptive, because those are really central, I think, to your paper.
They definitely are central. So, okay. So UTOK brings them these lenses. I was just trying to, and UTOK gives us some lenses to think about the understanding the problem. 2 primary lenses. It could give more. One is character adaptation systems, and it translates the sort of schools of thought and says, actually, they're focused on systems of adaptation. There's a habit system. There's an experiential system. There's a relationship system. The influence matrix maps that. There are defenses that we're regulating, and there's a justification system that actually cognitive therapy. I actually argue cognitive therapy, existentialism hit the justification system. Psychodynamics hits the defense and relationship. Experiential, gestalt processes hit the experiential system. Emotion-focused therapy as well. And then behaviorism is mostly about engineering the habits. I mentioned that because it provides a gestalt to help understand the person. And then what are we actually treating? There's a thing called triple negative neurotic loops that emerge essentially out of this model. It says the thing that gets people really in trouble, that brings them to psychotherapy, is bad shit happens, bad events happen that hit their emotion system. And then they have secondary maladaptive reactions to that to try to grip, often through avoid. I don't want to talk about this. I want to repress it. Doesn't matter, intellectualize. Blame. I can't believe I'm so bad this happened to me. I can't believe the world. I can't believe you did this and can't let go of the blame, get him, or misguided control. I have to do everything to prevent this from happening again. Those are the ABCs that trap people. And if they get trapped, the analogy is like bringing water to a grease fire. And essentially, it makes sense that you'd want to avoid this or blame somebody for this. But if you do it in a particular way, you're actually making the situation worse. And that's going to result in a vicious narrowing into the cave of behavioral shutdown, potentially, where you can't let go, can't accept an attack. Finally, then, COMMO says that there are a set of principles and processes that we can use this unified language to say, well, what happens to people? Well, you want to shine. There's a reactive network of responses that is the secondary reaction that's maladaptive. We can get people to step outside of that and reflect on it in a metacognitive view. If they bring a particular relationality to that, either with it between people or to themselves in a metacognitive view that's curious, accepting, loving, compassionate, and motivated toward value states, you can dissipate this set of negative reactivity grip and transform it to a much healthier way of being. In fact, at a principle, how you exactly do that's a good question, but these are the principles and processes by which you can stop maladaptive patterns from driving people into problematic entrenched structures and reverse them into healthier, happier living. Okay. So, yep, tried to do it in 5 and had to do it. Sorry if I cut in. So I did want to shut up quickly because I really want to hear what these folks say. So I'll now, thanks. I guess that is important. And if anybody wants to learn more, I even have flashlights about this COMMO thing. So you can you shine your COMMO flashlight on your neurotic loop. We even got trinkets to help with that process.
It's a very illuminating concept.
Well, couldn't resist. There it is.
You talk merch, man.
Yeah, we're getting coins and we're getting to sell mugs and everything. So you hold on your seats and we're going to be bringing that. So anyway, let's go to Stephen Bacon and so that he can share his thoughts and reflections about this.
Okay, that sounds great. I prepared some very rough PowerPoint slides, and I assume that I'm going to be able to share my screen here.
You should be able to.
Let's see if it works.
Yep, here we go.
Can you guys see it?
Yep.
Okay. So the beginning of this, I put in reference to Daniel Kahneman, and Many of us know that he recently passed, so I've been reading a bunch of tribute articles to him. Probably many of you have done that also. And I became aware through those articles that he was a big advocate of something that was called adversarial cooperation, where he'd intentionally invite somebody who didn't agree with him to reflect on his ideas and so forth. So I am nominating Greg for the Adversarial Cooperation Mini Award because Greg knows my work and is aware that my view of Common Core is quite different than his. And so I just wanted to, I think we all love Daniel Kahneman, but also that adversarial idea is a really great and important idea. Okay.
Amen.
Okay, so I'm going to just start with some appreciative words. I've been a fan of Big History since I kind of woke up intellectually as a young man. And I do feel, Greg, that your work has really helped the field evolve, particularly putting psychotherapy and psychology in the context of Big History. It's very exciting. I look forward to your continued work on it. I think it's really important. For my work, there's a particular part of UTOK that's important. And that's something you referred to just a minute ago, which is plane 5, culture, person, and the justification point with plane 4, mind, animal. Because a lot of my work is about being clear whether we're operating in constructed reality or fundamental natural reality. And I think that the UTOK division of plane 4 to plane 5 is incredibly useful there, grounds it in evolutionary theory and Big History. And, when Berger and Lechman popularized the whole idea, they spent a lot of time talking about confusion between constructed reality and natural reality. But Greg, your model actually moves it forward. I do believe, though, that even though I admire that part and I'm very grateful for it, just giving you a compliment, I do think that the implications of that kind of are harmful to your Common Core paper. And I'll try to show why. So at any rate, now, I'm going to do a little bit of implicit hidden assumptions. So Greg makes reference to the great psychotherapy debate in his paper. The great psychotherapy debate is fundamentally an argument of whether specific factors have inherent power, specific factors being defined as techniques and the systems that underlie them. On the other side are the common factor people who say, no, it's all common factors. Everything is ritual beliefs and expectations. The specific factors say, I don't want to be a placebologist, hard to argue. But that's a really, really important thing. And as somebody who's been to CEPI conferences, this is almost never talked about. In CEPI, there's an assumption, most psychological integration, that techniques have inherent power, and our job is to try to work with psychological integration principles and look at the common things that underlie these powerful techniques. Everybody agrees that the common factor of the therapeutic relationship, et cetera, is very important. But the great psychotherapy debate is all about specific factors and do they have power. I'm going to give a tiny bit of history. And I know most people understand this history, but I want to make sure we're all on the same page. So the basic history of the great psychotherapy debate starts with the dodo bird finding. The dodo bird finding, of course, is the one that says all the systems, even though they use different techniques, different underlying philosophies, get positive results and their equivalent positive results. This has been a contentious finding because it means the death of specific factors. If the dodo bird is accurate, the idea that things that are so different, as I believe in the unconscious, I don't believe in it. I think neuroses are centered in the person. No, it's in the system. The idea that those different philosophies with very different techniques would get the same result, which is the dodo bird finding, suggests that all their differences are illusory and really they're doing the same stuff. In other words, no power of specific factors. So specific factor advocates had to attack the bird. And the attack on the bird was pretty simple. There's a bunch of studies that show that one approach is superior to another. There are dismembering studies that, and I'll be rough here, estimate that about 11 to 15% of the effect size of psychotherapy is due to specific factors. And then, of course, there's common sense. I do something with my client. It's important what I do. There must be some power in it. The common factor people responded with, well, our meta-analyses keep coming out that everything's the same. And then they said, look, there's a lot of bad design and there's huge amount of allegiance factors. Allegiance factors means that the person doing the studies preferred one approach to another, and so did the therapist doing it. As most people know, they just argued a stalemate, and it never got resolved. With all the arguments done, no specific factors people went away, and no common people said, oh, you guys are right. So that sits there as a stalemate, and it looms over our field. Now, that argument is not very important to practitioners in the field, because practitioners in the field are essentially highly influenced by the medical model, which Greg already defined: assessment, diagnosis, application of evidence-based technique, and improvement or resolution of the problem. So we know that the medical model includes common factors. Even in medicine, they think a bedside manner is important, and in psychotherapy, it's considered very important. But psychotherapy integration has taken this debate, which is stalemated because of the ubiquitous acceptance of the medical model in the field, and they just rush on past the fact that it's never really been proven that psychotherapy has specific factors with inherent power. Rather important point. Now, what I'm about to say is literally my work, but I have to footnote it. I got a lot of it from reading Wampold and Scott Miller and all that kind of stuff, but they don't present it quite as formally as I do. So I'm going to throw out some arguments that I'd like you to listen to really carefully, because everything I'm going to say rests on these arguments. The first one is the idea that if techniques have inherent power, that experienced people who know more techniques and who practice them more assiduously should do better than less experienced people. If techniques have inherent power, experienced people should have better outcomes than inexperienced. And a similar argument, trained people who know techniques should best lesser trained or untrained people who know fewer or no techniques. And the size of these effects should be clinically significant. There's no therapist I know, I have to include myself in that, who doesn't think my training and experience help make me a better therapist. So we expect that to be a fairly, robust finding. Now, what I have next is a minute literature review. The whole literature review is in an article that was, you can see the citation at the bottom. It was in the CEPI journal back in 2020. And so if you want to look at the whole literature review, you're very welcome to. I actually believe that these 4 points alone are enough to really be convincing. The first one is that large meta-analyses, very easy to look at years of practice of the therapist and see what correlation there is with outcomes. It's zero. And that is not one study or two studies, that's hundreds of studies. That's been replicated a lot. Zero effect from experience on outcome. The next one is devastating. Paraprofessionals, again, these are hundreds of studies. One meta-analysis had 125, another one had like 74. Paraprofessionals do as well and sometimes better than licensed professionals. And remember, paraprofessionals are essentially untrained. They may have a college degree, but it's in biology, and they got a few workshops when they're in a clinic, but their training is close to zero, experience much less. They get the same or better. The reviews of training that take a look at outcome fail to find any effect from training on outcome. There's a lot of effect of training on other things, like people are better at manualized treatments. They're better at some measures of empathy, but there's no evidence that training enhances outcomes. And then the last one is pretty compelling. Starting with the Stroop study, they take untrained therapists. Stroop study, of course, was college professors, and they found that the untrained therapists got the same equivalent outcomes as the trained therapists. Got replicated by Anderson in 2016. He compared fourth-year clinical psych students with fourth-year graduate students in history and biology. Had them all do therapy. Everybody got equivalent positive results. So, like I say, you're welcome to take a look at the detailed literature review. Whoop, where'd it go? That's not good. Sorry about that. That wasn't supposed to happen. Let me try to get back to the right spot. There we go. Okay. In sum, there's no evidence for experience or training effects. Hence, one should accept that techniques lack inherent power and common factors people have won the debate. And everything we write about how psychotherapy works should be based on the acknowledgement that there are no specific factors with inherent power. Worse than that, and I use the words intentionally, the training and the experience effects don't just apply to techniques. What are we trained in? What are we experienced in? All of psychotherapy's privileged knowledge, all the research, all the work on client characteristics, all the underlying systems, all the papers we've written, all of that trained people know. But because there's no experience effects and no training effects, that means our entire privileged knowledge is unrelated outcomes. That is a pretty terrible thing to say. But it logically follows from what I've just told you. Now, here's one important point we need to make. The privileged knowledge is unrelated outcome has to be divided into two parts. There are a lot of things we say in therapy that are techniques with inherent power. In this slide, I use the one, restful sleep is good for mental health. All of us have told that to clients. We believe it, it's true, and it makes a difference. In Greg's terminology, I would say that that operates in the mind-animal part of psychotherapy. But the real thing that I think is interesting is almost all the stuff in our privileged knowledge that has inherent power. I could have lunch with my sister-in-law, who's a smart lady, but knows nothing about psychotherapy. And she can tell me stuff like, have more friends and you'll be healthier. Restful sleep is good. Exercise can dispel. In other words, my sister-in-law shows that the stuff in our privileged knowledge that has inherent power is actually part of common knowledge, not part of privileged knowledge. So the EPPP that we all had to pass, that's all full of our privileged knowledge. They don't test too much. There aren't any questions that say, is restful sleep good for your mental health? True, false on the EPPP. That's what they don't test. Anyway, so the implications for psychotherapy integration, then psychotherapy integration becomes simple once you throw away specific factors. I have a quote here from Anderson, Lunan, and Ogles that they just have a way with words. And in 2 paragraphs, they put a summary of how to do psychotherapy integration once you understand there's no specific factors. I love certain parts. I love that quote where they say, at the same time, it may be said, paraphrasing Winston Churchill, that never has a subject contribute so little to outcome receive so much professional attention. I thought that was very clever. Then they go down and talk about, I'll let you guys read it because me reading something out loud, I think is not that helpful, but their final statement is, suffice it to say, techniques work in large part through the activation and operation of placebo, hope, and expectancy. And then they put the 3 points that are very similar to what Greg summarized when he was talking about Wampole. And they said that's what integrates all the schools of psychotherapy. It's the only thing that makes sense. And I think I've been talking for 15 minutes. So that probably would be a good place for me to stop. And I'm sure we'll get back to it during the discussion. Thanks a lot. And I'm interested in our next person.
All right. Yeah. Thank you so much. You and we did a You Talking with Greg. So folks, look up Stephen Bacon, You Talking with Greg. He lays that out for a whole hour and we delve into the implications. I look forward to coming back and teasing out some of these elements. I think we'll go ahead. The game plan is to go ahead and shift to Dre. And is that right? Do we
say shit to Dre?
shift? no, dude. No, go ahead, friend. All right.
So, Stephen, you're clearly a smart guy who's thought about this deeply, and but I'm going to have to be an adversarial collaborator. So I think we'll talk about this more. But this dodo bird suggesting the death of specific factors or mechanisms of change, I think, is completely untenable because those dodo bird findings derive from comparing treatment packages. As in contrast to actually studying the specific mechanisms, the specific interventions at specific client marker times. And I also think it's very possible to appreciate both common factors and specific factors. I don't think it has to be both ends. So I hope we can talk more about that, at the end. But so anyway, I do have a little paper here. And Jack and I are going to be drawing on a paper that is currently revised and resubmit at the Journal of Psychotherapy Integration. It's titled Issues in Achieving a Unifying Consensus on Mechanisms of Change in Psychotherapy. So whereas Greg and Stephen were talking primarily about common factors, but there's a lot of overlap with common factors and principles of change, Jack and I are going to be talking more about the critical importance of mechanisms of change. And I think I'm going to be giving Stephen some an aneurysm here during the, I didn't know what you were going to talk about, but anyway, mechanisms of change as one, an essential component of the field's core knowledge, and two, as an integral component of unifying the field of psychotherapy. So as a very brief definition or description, because Jack will go into more detail about this, mechanisms of change are how change or effective outcomes actually come about. So said another way, it's why it is that a given intervention actually works. So like a principle of change or common factors, those are things that therapists do. Mechanisms of change are saying what's going on within the person that leads to the actual positive outcome. So again, before getting into the nuts and bolts of mechanisms of change, we need to recognize that the process of reaching consensus regarding what constitutes core knowledge of our field raises ineluctable epistemological issues. So the overarching question in the paper that Jack and I wrote was that in the context of its potential contributions to a core body of consensual knowledge, which again our field lacks, can there be a unifying consensus on mechanisms of change? So I'm going to contextualize the issue, discuss some of the significant benefits that derive from understanding mechanisms of change more deeply, and I'll discuss some epistemological issues involved in reaching a consensus on a common core. And then Jack's going to go into some of these other issues in more detail. So there are a lot of scholars like Marv Goldfried, Gaines, Simon Nutjens, who have ardently and persuasively argued that despite being more than a century old, the field of psychotherapy is at a costly impasse. It's languishing in a Kuhnian pre-paradigmatic scientific state, and thus having yet to advance its evolution into a more mature science. And they attribute this developmental stasis to the field's lacking consensus regarding the core knowledge of psychotherapy. Like Greg said, we don't have cumulative knowledge, and we're talking about nothing less than psychotherapy's theoretical, empirical, and practical core. So despite pursuing evidence-based practice as a holy grail for advancing psychotherapy's scientific status, the field has yet to achieve consensus on the meanings, methods, and implementation of evidence-based practice. So Greg contributes to understanding what is conceptually necessary for the field to move toward consensus, making it clear that, and this is a quote from his most recent book, for a system of knowledge to be truly scientific, it also needs to be grounded in a shared conceptual system that is up to the task of organizing the field of empirical findings into a coherent picture of reality. So neither the single school theories nor the first four psychotherapy integration pathways are up to this conceptual task. As Witherington and colleagues have emphasized, only meta-theory affords the conceptual capability of zooming out and then organizing domains like theories, principles of change, mechanisms of change, and so forth. So and I think I can speak for Jack, are in complete agreement with Greg that in addition to needing a common core, we also need meta-theory to frame and organize common factors, mechanisms of change, and so forth, not to mention like theories and techniques. So as in other fields of study, achieving consensus is pivotal to dislodging psychotherapy from its developmental impasse and advancing it in a paradigmatic fashion. Toward this end, Marv Goldfried, all the way back in 1980, incisively laid out a seminal pathway centered on trans-theoretical principles of change for transcending this stultifying state of affairs in service of facilitating movement toward greater consensus. Now, principles of change are found at an intermediate level of abstraction, like theories are the most abstract, techniques are the most concrete, and principles of change, there are many different interventions that can achieve the same principle of change, and they're trans-theoretical. So over the past decades, Goldfried and colleagues have, rather productively pursued this path. They've identified, elaborated, and developed empirical support for 5 such principles of change. And I think it's very important that Goldfried never claimed that principles of change should be the sole pathway to achieving a core consensus. Okay. So again, I like epistemological issues. So some of those that are involved in the pursuit of a common core. So I truly and deeply appreciate Goldfried's prescient and continued calls for consensus. But a call for consensus does raise important epistemological issues. So to begin, how will we know when we have attained consensus? This actually is not a trivial question. So like assessing the breadth and depth of agreement and deciding how much agreement is enough is not a black and white matter. And you have to think about what are the roles of dissent and disagreement when you're trying to form consensus. So I'm drawing from several philosophers of science who specialize in social epistemology. So Boaz Miller argues that an epistemic community may declare consensus if the agreement is well institutionalized or if the dissent is marginalized. But what specifically constitutes well institutionalized agreement and marginalized dissent? Delsen, a philosopher who specializes in the philosophy of science and epistemology, he stressed that there's no single correct way in numerical terms to draw a line between consensus and disagreement. So in light of the calls for consensus, which I think many, if not most of us are for, by what methods can we actually obtain consensus on this core body of knowledge? And maybe more specifically, under what conditions can we justifiably determine that this consensus is knowledge-based or otherwise epistemically justified? So Jack is going to go into more detail on this, I think, but let me say here that before we can achieve consensus on a common core, we really need consensus on our definitions and terms. And so, and we should remind ourselves that a fundamental purpose of any scientific discipline is to advance knowledge. And without abiding by this principle, consensus building is impossible. So essentially, a mature discipline must have a body of foundational knowledge that's consensually agreed upon by professionals within that body. Delsen writes that, quote, the presence of consensus on a scientific theory is often taken to indicate that that theory is at least substantially correct. Other scholars in this area argue that the notion of scientific consensus strongly suggests that something is true. So, again, we have to have agreement on how our terms are defined, because if our goal is to establish consensus on the common core, on mechanisms of change, and so forth, we have to mean the same thing when we're referring to those concepts. Here's a quote from Delsen. Among social epistemologists of science, it is well known that scientists do not invariably or even usually evaluate theories by assessing the scientific evidence for and against such theories. In short, scientists often place a great deal of trust in each other's judgment. On this view, then, the quick emergence of consensus, even on very complicated or delicate scientific issues, can be explained by social interactions in the presence of trust between scientists. So philosophers of science who specialize in social epistemology, as well as historians of science, recommend deferring to the consensus of experts only if it's knowledge-based or epistemically justified. According to Stajenga, there are three conditions for consensus to be knowledge-based. The first is inclusivity. So this consensus-forming process should include all available evidence. The second is constraint. That these processes should constrain intersubjective assessments of the hypothesis of interest. And evidential complexity. These processes should assess evidence on multiple relevant evidential criteria. So in a similar vein, Miller said for consensus to be knowledge-based, it had to be consilient, theme of the conference. And that basically means, having several different types of evidence converge in support of the construct or theory. So what is the role of dissent and debate in reaching consensus? Right. So Goldfried ended a seminal article with, quote, the time may be ripe to address the question on what can we agree. I think an important twist on that question might be, can we even agree that we all, or most of us, want to agree? Like, in other words, can we agree that we want to achieve consensus? Actually, my sense is that those theorists, researchers, and practitioners who are excessively attached to their preferred approach are going to be resistant to agreeing. That's to say, resistant to reaching consensus. Greg, it looks like you're frowning your brow. I can't help but notice. I guess this will come out later, huh? All right.
Just thinking. Just thinking.
All right. I feel my social influence declining as I'm. Okay.
It's up there.
What can you mute? Can you no? What Gaines and colleagues are saying our discipline needs to do is no small matter. Oh, I didn't read the quote. Okay. Gaines and colleagues wrote that the discipline will need to set aside our deeply rooted rivalries and place greater value on creating a knowledge base that can be shared by all. So I think that what they're saying we need to do is no small matter, because I encounter a lot of people who, so like I got trained in ISDP for quite a while, and my supervisor, who was not excessively attached, came up with this term, ISTDP attachment disorder. And you can have this, you can be CBT attachment disorder, EMDR attachment disorder, right? There are a lot of people who just see the world through, their preferred approach. And these people are not going to be inclined to value more trans-theoretical or meta-theoretical principles, because it's going to require them to see beyond their highly preferred approach or method. So it is worth noting that although dissent is incompatible with unanimity, dissent is compatible with consensus. Dissent is not the opposite of consensus. In the paper that Jack and I are drawing from, we discussed several methods, like formal systematic methods for achieving consensus that have taken place in other, scientific disciplines. One of those is the Delphi method, but I don't have time to go into that here. Okay, getting to mechanisms of change. Again, Jack, I know I'm repeating myself, but I think a lot of people don't quite make the distinction. Mechanisms of change are how the change actually comes about. Why does the intervention actually work? So this domain of study was propelled by Kasdan's 2007 seminal chapter. It's titled Mediators and Mechanisms of Change in Psychotherapy Research. Since then, many scholars, I'm thinking right now of Simon Nutgens, wrote, consensus has formed that an integrative approach vis-a-vis mechanisms of change is best positioned as EST's successor. ESTs are the empirically supported treatments. So in other words, to advance the current state of evidence-based practice, the field should shift its focus from ESTs, which again compare treatment packages, to an evidence-based psychotherapy based on mechanisms of change. I personally believe that this kind of focus is an utterly essential aspect of unifying the psychotherapies. I may agree with Greg that first we should do the common core and factors, but I think for our field to really mature, we need to explore that deeply. And here's an analogy I've been making recently, and my two students here will know I brought this up just the other night. So knowing that if you want your houseplants to do well, they need sunlight and water. Okay, that's akin to understanding and implementing a principle of change in psychotherapy, right? But only understanding photosynthesis explains how the plants use sunlight and water to synthesize their food. So one of the students in class has said, well, if all I want is healthy plants, I don't need to understand photosynthesis, which is like someone saying, if all I want to do is help my patients, all I need to do is understand how to implement principles of change. And that may very well be true. But for a field to become a mature science, surely some of us need to know how and why common factors or principles of change work. So I find it noteworthy that Gaines and Goldfried wrote that, quote, the field of psychotherapy generally has few apparent examples of agreed upon core knowledge. So Jack will soon go into detail about this. I'm putting a lot of pressure on you, Jack. So, and I'm trying to mind read what you're going to do. But there is so first of all, I need to thank Jack. I didn't know much about mechanisms of change 6 or 8 months ago. He invited me to co-author this paper, and we took a deep dive. And so I'm just so grateful to have learned more about this. I knew a little bit about them, but I would have fallen prey to what I'm just about to say. There is a remarkably surprising amount of conflating principles of change with mechanisms of change in the literature by very smart, competent researchers. There's also a tremendous amount of equating mediating variables with mechanisms of change. I'm not going to name names, but just very, very smart people at the CEPI that was just 2 days ago, they were doing it all over the place. I was like, so anyway, to my knowledge, or from my perspective, there actually are very few actual mechanisms of change that have been identified and understood. I think the best example I can think of is memory reconsolidation. But you can find 100 things in the literature that are called mechanisms of change, and I would virtually bet my life that like 99% of those are not mechanisms of change, right? So we're not clear on our definitions and terms. So, but why should we work to better understand mechanisms of change? Or phrased differently, what are the benefits of understanding mechanisms of change? I think that the more we learn about these, the more distilled our understanding of how and why therapy works will be. And that can allow us to choose the most effective strategy to activate specific change processes that a specific patient needs. Now, this may be sounding like the medical model, and I guess we can discuss that later. Given that we are confronted with hundreds of interventions to draw from, I think knowing precisely how change occurs is very valuable knowledge. I think this can help us truly optimize our therapeutic efforts by guiding. Now, again, I still believe in common factors, but I think there are going to be times when, if we can be guided to interventions that are most powerful and effective, that we can then minimize or eliminate those that are less potent or less effective. And I think without understanding how therapy works, we're like sailors in a deep fog without a compass. How do we make decisions like knowing whether to just empathize or to interpret, challenge a defense, offer support, without knowing whether, how, and why these strategies activate the most important processes of change for a given patient at a given time? So there is an extensive range of reasons that demonstrate why more deeply understanding these mechanisms of change is indispensable to the further development of the big four in psychotherapy: theory, research, training, and practice. And of course, those are all inextricably linked. For example, significant, robust, replicated research findings should necessarily influence our theories, as well as the way we practice and train clinicians. After all, I still think it's the case that the very best practice will be informed by our best science. And that certainly is not just RCTs. Okay. So in the domains of theory, research, practice, and training are all overarchingly in service of and focused on optimizing therapeutic change. So I think the importance and value of knowing how a given intervention brings about change will be all the more appreciated when considered from the standpoint of this critical concept and process of responsiveness, which is characterized as doing the right thing at the right time to improve clinical outcomes. And among key considerations in responsibly meeting the patient's needs is clinical judgment, centered on the question, what mechanism of change should be activated at this specific time in this specific context? So, according to Kasdan and Knock, the primary problem with efficacy RCT research is not the minimal generalizability of the findings of RCTs to real-world patients, therapists, and clinics. The real problem in their mind and my mind is that RCTs focus on treatment packages rather than it's what what Greg calls the horse race, CBT versus psychodynamic. Well, what parts of CBT? What parts of psychodynamic? Rather than focusing precisely on how specific interventions work. So without understanding the actual, and I am nearly done, without understanding the actual specific processes by which change occurs, I think our work as clinicians is greatly hindered. We may use an intervention, but not expertly, or we may use the strategy quite well, but then we switch strategies before an adequate dose was offered. So I think a better knowledge of mechanisms of change would advance and refine the development of our theories of psychotherapy because it can reveal which components are essential and which can be dispensed with or minimized. And if our field were to achieve consensus on mechanisms of change, I think the impact on how clinicians are trained would be enormous. So although specific interventions, which are derived from specific approaches, would still be taught, they would be taught within the overarching context of what specific mechanism of change a given intervention is attempting to activate. I think this would help reduce the siloing and competition between the different therapy camps. And I think it would lead to a more unified field that appreciates what each approach brings to the field. So I will here turn things over to Dr. Jack Anchin.
Thank you. Thank you very much, Andre. I want to start just with a very, very brief anecdote, which is that as Andre and I were working on our paper very intensively and collaboratively, wonderful collaboration. I told him along the way that if I was going to put like a colloquial title on some of our ideas, it would be that, consensus is desirable, but not so fast. Okay? It's going to take some time. So in that regard, what I want to focus in on is terminological and definitional issues in achieving consensus on mechanisms of change. Some of this material will echo some of the material covered by Andre, but we'll go into some greater depth. So I want to start with a quotation, which I just love. The quotation is, "Science travels on its vocabulary." Science travels on its vocabulary. Okay? This strikes me as very astutely and succinctly conveying the essential role that a scientific field's conceptual terms and definitions play in the progress of that field, or the lack thereof. In that regard, there seems to be consistency in the view that in an area of study, when terms, concepts, and definitions are inconsistent, ambiguous, and/or imprecise, scientific progress is hampered. Okay, now why is that? Well, some of the reasons that have been cited, and all of these work against establishing a unifying consensus, are the following. One, ambiguity, inconsistency, lack of clarity about terms and definitions and concepts. Problems in that area: one, impede effective communication and debate. Two, produces misunderstandings. Three, it quashes hope for theoretical consensus. And four, it serves as an obstacle to the broader integration of results from different studies. Okay, to obtain a consensual core of knowledge about psychotherapy, it's fundamentally important to have our terms and concepts clearly defined and to have agreement on how those terms are defined. Briefly, I want to mention a study by Sudor and colleagues published in 2017 that described in great detail, beautifully illustrates the need for and the extensive processes involved in achieving a unifying consensus on the definition of one core concept, in this case, advanced care planning, in order to guide and advance initiatives in research, practice, and policy making in that specific field. Very quickly, just to illustrate the intensity and the temporal necessities in trying to establish consensus. They used the Delphi method. They organized an international panel of 52 researchers, clinicians, legal experts, and policymakers, as well as a patient advisory board. And they went through 10 rounds of collectively narrowing down definitions of advanced care planning until they achieved consensus on one definition. Okay, that's just to get consensus on one term. And you can hear the elaborate nature of the process and how that takes real time. Okay, so if the goal is to establish core consensual knowledge about psychotherapy, then at any scale, whether for the level of the field as a whole or for the more specific level of mechanisms of change, it's essential that we all mean the same thing when we refer to one of those specific concepts. So in this light, what I'd like to do is bring to the fore three prominent terminological and conceptual distinctions pertinent to mechanisms of change, and briefly discuss definitional issues associated with each that impede achieving a unifying consensus about mechanisms of change. And Andre's and my goal in doing this is that at one level, we want to advance the definitional clarity necessary, but far from sufficient to establishing a consensual body of knowledge in the area of mechanisms of change. But there's also a broader objective, which is to illustrate the kind of epistemological work that needs to be done before consensus on mechanisms of change can be achieved. Okay. The first distinction that I want to make, and Andre alluded to this, the first distinction involves a terminological and conceptual distinction between mechanisms of change and principles of change. Okay, both of these concepts share the goal of optimizing the effectiveness of psychotherapy, but the fundamental meaning of each is different, and yet in the literature, they're often used interchangeably or they're conflated. Okay, the essential difference between these two concepts is that mechanisms of change pertain to the patient, whereas principles of change are therapist focused. Okay, coming back to Kasdan's definition of mechanisms of change, alluded to by Andre, Kasdan says that mechanisms of change refer to the processes that explain why therapy works or how it produces change, unquote. The focus here is clearly on patient processes. Okay, a mechanism of change describes the unfolding series or sequence of internal events that are activated by a given therapeutic intervention, and of crucial importance, that are viewed as causally responsible for subsequent positive treatment outcomes. Okay, it's this unfolding process that actually brings about the therapeutic change stemming from an effective clinical intervention. In contrast, principles of change, as reflected in Goldfried's 5 principles, which I want to get to in a moment, are chiefly therapist-focused because they identify different therapist actions and processes that have been empirically demonstrated to be associated with positive outcome. Okay, just to touch on these, give you the picture here. These are Goldfried's 5 principles of change. Okay, fostering the patient's hope, positive expectations, and motivation. Okay, fostering. Facilitating the therapeutic alliance. Facilitating. Increasing the patient's awareness and insight. Increasing. Encouraging corrective experiences. Encouraging. Emphasizing ongoing reality testing. Emphasizing. Okay, all of those really fundamentally have to do with the therapist's actions and processes vis-a-vis the patient. Okay, so a principle of change translates evidence-based knowledge, okay, about techniques that work into trans-theoretical recommendations that provide a therapist with guidelines for how to interventionally or relationally proceed on the basis of specific patient, relationship, and/or technique factors. And by virtue of being trans-theoretical, techniques from different theoretical orientations can be used to implement the principle. Okay. Some useful illustrations, again, just to put a little more meat on the bones. Some other illustrations of principles of change come from another team of clinical researchers who, along with Goldfried, have done work on identifying principles of change. In 2006, this is Castonguay and Butler. They published a book of containing 61 evidence-based principles of change. 13 years later, in 2019, Castonguay, Constantino, and Butler published a volume updating the 2006 volume, where they presented a revised list of 38 evidence-based principles of change, each providing a specific strategy to guide therapist interventions or processes. Here's just several examples. Okay. The principle of change based on the patient would be, just see this, clients with moderate to severe impairment and or fewer social supports will benefit more from psychotherapy when their therapist helps them address their social or medical needs. Okay. Principle of change based on relationship factors would be the following. Clients experiencing more therapist empathy may benefit more from psychotherapy than clients experiencing less therapist empathy. Okay. Empathy, I suppose technically could be called a technique, but it's a relational process that is part of how the therapist interventionally interacts with the client. A principle of change based on therapist factors. Clients whose preference for religiously or spiritually oriented psychotherapy is accommodated by the therapist may benefit more from treatment than clients whose preference is unmet. Okay. So you can see from these examples that principles of change are really focusing on the therapist's actions and the therapist's processes. Okay, mechanisms of change are referring to what goes on in the patient that brings about change from those interventions, whether principled or not. Okay. Now, this conceptual distinction between mechanisms of change and principles of change is not splitting hairs. This distinction has important implications for both research and practice. For example, one of the directions of psychotherapy research on cognitive behavioral therapy, CBT, is designed to sharpen knowledge of the links between specific cognitive behavioral interventions and the respective mechanisms of change that they activate. Okay, in the context of discussing this research, one group of researchers explicitly underscored that, quote, in order to understand how therapy works, it's crucial for researchers to distinguish between therapy procedures, i.e. techniques, which are embodied by principles of change, and mechanisms of change in their theories and models. Okay, but critically, they also point out that failure to maintain the boundary between cognitive behavioral treatment techniques and mechanisms is a common problem in psychotherapy research. For example, many measures that are used in outcome research include items that refer to techniques and other items that refer to mechanisms of change. So whatever the findings are on a measure that conflates the two, it's not clear to what extent the findings are about techniques and to what extent they're about mechanisms of change. Okay, and this conflation also exacts costs in the clinical realm. When a therapist is incorporating principles of change into how he or she is working with a patient, the answer to questions about when and how to implement a given principle of change may depend in part on the mechanism of change one is seeking to activate. If the therapist fails to distinguish between principles of change and mechanisms of change, then judgment and decision-making about how to proceed can become muddied, contributing to less than optimal therapeutic intervention. Yeah. A second area in which there are definitional issues associated with mechanisms of change, and thus touch on issues, problems, and achieving consensus, lies in the distinction between mechanisms of change and change processes. Okay, this is a distinction that touches on the issue of achieving consensual understanding of definitions. When definitions expand and concepts expand and the terms used to denote those conceptual expansions change. Okay, in the literature, the terms mechanisms of change and change processes are often used synonymously and interchangeably. But there is a treatment approach referred to as process-based therapy developed by Hayes and Hoffman that in fact draws a very explicit and meaningful distinction between mechanisms of change and change processes. Okay, process-based therapy is a trans-theoretical meta-framework for understanding and treating psychological disorders, dysfunction, and emotional suffering that emphasizes not formal diagnoses or a priori theoretical explanations of the patient's difficulties, but rather it focuses on the specific components and processes that comprise the patient's difficulties, and therefore the specific components and processes that need to change. So process-based therapy very much focuses on change processes. Okay, change processes are a central pillar of process-based therapy, and it's a terminological and conceptual shift that embodies a significant expansion of the concept of mechanisms of change. Okay, for Hayes and Hoffman, the term mechanisms of change implies a linear, unidirectional, sequential model of change. So when a therapist intervention brings about change, according to the mechanism perspective, it does so by impacting variable A, which impacts variable B, which impacts variable C, and so on. A one-way causal influence process, sort of like dominoes. Okay. They prefer the concept of a change process because it encompasses a fine-grained picture of how change happens for a given individual that's more in sync with the complexities of health and disorder brought about by complex dynamic systems theory, which I absolutely love. Okay. From a process-based perspective, from process-based therapy view, systems perspective of the patient's difficulties and clinical change are conceptualized as multivariate, nonlinear, and is occurring over time scales. Okay, for example, a person's difficulties often involve multiple variables. A specific problem like marital conflict, they encompass specific symptoms as reactions to the problems, depressed mood, irritability, sleeping difficulty, fatigue, and they encompass, thirdly, contextual factors. For example, the marital conflict may center on how to discipline a child who is transitioning into adolescence and challenging limits. Okay. Additionally, these variables are interrelated in nonlinear ways. Just to give one example, the marital conflict may be contributing to the patient's irritability, which feeds back to heighten the frequency or intensity of getting into conflict with the spouse. In other words, a positive feedback loop. Okay. Now, since the difficulties that bring a person into treatment are multivariate and nonlinear, the process of change is also likely to be multivariate and nonlinear. So let's say that a therapist helps the couple get on the same page about how to discipline their burgeoning adolescent. Okay. Getting on the same page as a couple improves the patient's mood, their sleep improves, they have more energy, and their irritability dissipates, which collectively feeds back into reduction in marital conflict. Again, here, a multivariate nonlinear change process. Okay. There isn't time to elaborate here, but there is a method called closed-loop network analysis that lets one visually depict these different components of a problem and the nature of their nonlinear interrelationships. It's an incredibly rich and surging area that, unfortunately, there isn't the time to get into, but it speaks to the multivariate, nonlinear nature of clinical problems and of change. Now, the purpose for shedding light on this definitional shift and conceptual expansion of the mechanism of change concept is to attune researchers, practitioners, trainers, and trainees to the fact that despite the frequent usage of the term and concept mechanisms of change, its connotation of change as a sequential and linear process limits that conception's utility. Thinking in terms of change processes can shift the focus to the multivariate, nonlinear intricacies and temporal intricacies of how change actually occurs. And this provides a more accurate and robust basis for pursuing consensus about how clinical change happens. Okay. A third conceptual issue that bears on reaching a consensus about mechanisms of change is the conflating of mediators and mechanisms of change. Okay, a very sharp distinction has been drawn between mediators and mechanisms of change, and yet, as mentioned by Andre, a surprising percentage of researchers conflate these two concepts. Okay, here are examples of mediators. Insight, that is helping the patient to understand something. Cognitive restructuring, is a mediator, entails fostering more accurate thinking. The acquisition of coping skills, for example, learning how to regulate emotions, is a mediator. Okay. Using these examples as backdrop, a mediator is a statistical precursor, a first step, as Kasman called it, toward identifying and examining mechanisms of change. Technically, a mediator is a variable or construct that shows a statistical correlation between an intervention and the outcome it produces, but it doesn't delineate the causal process through which change comes about. Okay, Tryon in 2018 crystallized this difference beautifully. Mediation, this is a quote, mediation is to mechanism what correlation is to causation. Just as correlation is not proof of causation, mediation is not proof of mechanism. Let me repeat that. Mediation is not mechanism. Rather, mediation is to mechanism what correlation is to causation. Just as correlation is not proof of causation, mediation is not proof of mechanism. Okay? So a mediator is an intervening variable that links an intervention to the treatment outcome it brings about. Okay, for example, an interpersonal psychodynamic therapist may help a patient understand gain insight into a specific interpersonal problem they're having, for example, quickness to anger. And they may help them understand this by explaining how the problem relates to experiences in their family of origin. And based on that insight, the client shows progress over time in becoming less quick to get angry at present-day significant others. So insight is correlated with the change the patient is making, but it doesn't really explain how the insight produces that change. What's the mechanisms of change? What's the process that unfolds that by virtue of gaining insight, the patient's quickness to anger lessens? So a mediator is not itself a mechanism of change, but it does functionally point in the direction of a mechanism of change, the actual unfolding change process that explains how and why an intervention brings about change. Or as one researcher crisply put it, quote, the mechanism is the phenomenon to reveal, the mediator can be the mean to this end. Okay, now, over the past 15 years or so, there's been a tremendous amount of research on identifying mechanisms of change along many dimensions. Just as some examples, different mechanisms of change involved in how different disorders change have been studied. There's been a focus on mechanisms activated by interventions associated with different theoretical orientations. There are mechanisms of change based on the stage of therapy. There are mechanisms of change based on the patient's developmental stage, and many other dimensions that have yielded, allegedly, mechanisms of change. But the problem is that despite the clear distinction between mediators and mechanisms of change, when researchers identify one or more mediators, they infrequently misinterpret the mediator as being a causal mechanism of change. And you see this clearly, straightforwardly in the titles of so many of these articles that talk about mechanisms of change, and in their discussion sections where they refer to the mediators they've identified as mechanisms of change. Okay? So, since these researchers are not really identifying mediators, how can we achieve consensus on mechanisms of change? So, just to conclude, I want to end my presentation with another quote and just briefly some brief comments. The quote comes from another researcher in the area of mechanisms of change. Quote, the consensus regarding the mechanisms of change in therapy may not soon be reached. Consensus is a difficult to achieve goal. It is, after all, complicated, unquote. The three definitional and conceptual distinctions that I've discussed are part of what's complicated. Okay, but collectively, it's clear that the road ahead in pursuing consensus about mechanisms of change is daunting. But if consensus is to be achieved, it's a road that the field must go down with caution, but also with commitment and intensity. Okay, and that's really kind of all I want to say here. I guess to summarize the major point, we believe, Andre and I, that mechanisms of change need to be part of a consensual core. They're so important. They have so much information that they provide, but there are obstacles to achieving that consensus that need to be borne in mind These are identifiable and need to be addressed. Caution, but commitment is needed. Okay, and that's about it.
Okay. All right. Thank you all, each of you, for your presentations. I'll offer some feedback. I'll throw some questions that I have out there, and then we can see where to go. I'll go back to Stephen, and then I'll go to Andre. And first off, I think one of the things we're seeing is that the multiple ways in which this field can be gripped, and differences about what can be aspectualized. But so, Stephen, let me go to you in relationship, because there's a fine line, isn't there, between basically saying, well, we don't really have any specialized knowledge, and training doesn't impact. And yet at the same time, in that article, and I'd just like to hear you think about it. Well, when you approach the field, or when you would, if you were to train people in how to become psychotherapists, can you then talk a little bit then about the positive side? I mean, I think what you bring is a pretty devastating critique, and we can talk about its legitimacy, and I'd be happy to share about that. It's a devastating critique on the one hand. Is there anything positive to then say? And if so, could you then relate that to what I say on the positive side? And do you see overlap? Is ComMO really too specific in relationship to what it offers? What would you say would be specific in terms of the kinds of things you would try to elicit based on what we know, so that individuals who enter the field would then grip onto things? Because I know you say and invite individuals to consider ways in which they might develop as a therapist that you think have some validity. And then I'd like to contrast or compare that a little bit with what is offered in the Common Core model. So can you offer your thoughts about that?
I'll give you a quick analogy of that.
Mm-hmm.
Let's say we're in a culture where the theory about mental health is possession by malevolent spirits. So we're all exorcists, and we believe their bad spirits come in, and we have our way of finding out which spirit and which exorcism fits which spirit. One of us, let's say you, travels to another country and learns that the spirits are constructs. Now you come back, you still have to heal by exorcisms, because that's the cultural requirement. What's the edge you have over a standard exorcist now that you're an enlightened exorcist? Well, I would say you have substantial. Let me just list a few of them. Number one, you're more optimistic. You're not scared that there are really bad spirits out there. Number two, you're aware that it's not the exorcisms that are healing people, and it's not the identification of what type of spirit. It's the way the client believes you. So you're going to be more client-centered as an enlightened exorcist than the rest of us. So less frightened, more optimistic, more client-centered. And then you can go a little bit further. Remember, I told you that I really liked your person culture differentiation from mind animal?
Yep.
So in the person cultural definition, I use the word constructed reality for it. Constructed reality is different than fundamental reality. In fundamental reality, across all the cultures, how to build a suspension bridge is going to be the same. But how to be a good woman is not. That's going to be very culturally variable. That exists in constructed reality. The question for all of us is, to what degree does psychopathology exist in constructed reality versus in fundamental? Now, we're all very aware that you can get brain tumors, obviously, in fundamental reality, but we refer those to a neurosurgeon and so forth. Fundamentally, when you use talk therapy, you're saying, I'm going to operate in constructed reality, and I assume that most of what my person is experiencing is also in constructed reality. So if we take Milton Erickson, who I think he did a lot of things that impressed a lot of people, but there's one thing, in fact, this goes to mechanisms of change. So he has a famous anecdote where a woman starts, she's a school teacher, she starts breaking down with a paranoid delusion. Like, I don't remember what it is. The FBI's after her, or students are going to poison her. I don't remember what it was. She goes to him, he hypnotizes her, and he says, you know what? I'm going to write down your delusion, put it in this manila envelope, and lock it in my safe. And so you won't have to worry about it anymore. It's effectively locked in this safe. She goes back and she works as a teacher with no more eruptions of the paranoid delusion. Now, that is a very weird outcome. That is a very weird outcome. But when a person understands that you're operating in constructed reality, when you're an enlightened exorcist, exorcisms are all magical powers. And Milton Erickson, in that example, had a pretty magical mechanism. Well, I guess you're differentiating between a mediating or principle, mediating variables. But the results he got with that woman, by the way, the end of the thing, she kept it together well enough to get married, and her husband got transferred to another state. She came to Erickson and said, I'm terrified, because she would come back about once a year to get her latest paranoia locked up. He said, no problem, just mail it to me. And she moved out of state, kept mailing stuff about once a year. And 4 or 5 years later, she came back. Remember, in Milton Erickson anecdotes, they always get married and have children. It's like a requirement in those anecdotes. She was married, she had children, she was functioning fine. She wanted to make sure that all of her paranoid delusions were still being kept by Erickson and were locked in a safe. And so he concludes the anecdote by saying, I opened the safe and showed her all the envelopes. Anyway, I know it's a bit of a long-winded answer, Greg, but if you get access to constructed reality, you function like the enlightened exorcist, and certain mechanisms of change that are not available to people that believe therapy operates in fundamental reality become available to.
Interesting.
That really points to culturally sensitive therapy, because I've had lots of my hallucinations and delusions locked up, and they've stayed right there.
Yeah. All right, we'll have to try. Different. Maybe we need a different block box. One of the okay, so let me shift over to then Andre and Jack. I'll sort of ask you guys this. So I'm as I heard you. First off, I totally agree that this issue of mechanism change versus principles of change versus processes of change is a very confusing and ill-defined set of terms, and it's really important for us to get clear on those. I was curious, and I didn't hear this, and so this is one of the things that I thought there would be more focus on. That's why I was kind of like, because I wondered sort of where the direction was. But let me just put this at you. What, in your mind, do you guys have good frames for mechanisms of change? Like for me, one of the things that you could are there, and I think actually this would be something, depending on how you define mechanism, maybe that Stephen would say, yeah, well, there's fundamental reality and there's a particular kind of mechanism there. There's a different kinds of mechanisms in constructed reality. When you look at the field, do you see good delineations of mechanisms of change? Are there good examples? I'm thinking here of memory reconsolidation. That's where I would definitely go. And some people argue that's the epicenter of mechanism of change. Like there's one other than other basic learning structures. I know folks that argue for MR, memory reconsolidation, basically say all good mechanisms of change reduce more or less to MR. That is I'd like to get your take on that. Do you see that as a good example of mechanism of change? What do you think about their argument that there's really an epicenter? Is there a whole slew of mechanisms of change? So I'll that's enough for.
Yeah, let me stop there, because I mean, let me start, because in our paper, we gave two examples of mechanism of change. One was MR and the other was emotional processing. And as we need to revise and resubmit our article, I want to have a lengthy conversation with Jack, because I'm not confident that emotional processing is really a mechanism of change. I mean, I may be wrong. So I'm not going to mention this person's name, but this person is so high up in the mechanism of change world. I mean, he's guest edited entire issues that were all on mechanisms of change. And he just talked at SEPI, and I brought these issues up. I said, it just strikes me as there's all this conflation. And his response was very disappointing to me. He said, well, there's a lot of overlap between these constructs, common factors, principles of change, mechanisms of change. It's like, there's not an overlap between a mechanism of change and a principle of change. A principle of change may activate a mechanism of change, but I do think there's some overlap between common factors and principles of change. I don't think that's conceptually deeply problematic that there's some overlap there. But the way that it has been laid out, and I think it's a useful way, like starting with Kasdan and then Tryon, that the principles of change, if you read them, they are therapist focused. They're things, they are processes we're facilitating. And a mechanism of change is what is going on that causally produces the change. To me, that is a black and white difference. And Jack and I in our meetings were like, are we missing something here? Because the conflation is so pervasive, it's unbelievable. And so I probably, without both of us together, I don't think either of us would have trusted ourselves enough to write this paper, because it's like, I mean, is it possible that we're really missing something, Jack? I know it sounds arrogant, but I think they're all fucking wrong.
It's really interesting, because I actually had this reaction myself. And in fact, first off, let me state, and I already said this to you, but if anybody's listening, so the way in which I delineate the common core, the contextual, it's a principle and process context model. It is not a mechanism of change model. So the entire model that I'm laying out is the common core is framed as a contextual process model grounded in certain principles. So you'll say, well, what are the principles that I'm going to be operating from? I am not claiming anything in this model in and of itself. The unified theory would maybe open up some certain kinds of notions about the kinds of mechanisms of change, but the model itself is for sure. And in fact, the language of mechanisms of change is something that feels very slippery and difficult to get a handle on. And I guess that's what is that your conclusion also? And is that where your sort of paper, does your paper say, actually, here's a resolution to this? Is the paper saying, hey, this is a very confusing and conflating thing, so much so that I'm not sure we need to dive down in and do a lot of work to get consensus? Is that where, or do you achieve a way of framing it in a way that says, okay, I mean, it's clearly the delineation between what's within the patient and causally structured versus what's correlation and focused on the therapist? That's a great clarifying frame. I guess I'm curious if there's more to be said, or is that pretty much where you end and then you say, hey, MR does feel like a pretty good model for mechanism of change.
Can I jump in here just for 1 second?
Yeah, please.
The most obvious mechanism of change that is not MR. The most obvious one is that we are all taught by key individuals, first parents and other people, what reality is. So when somebody who has high status says, think this way and feel this way, we are programmed to be influenced by that and to just take that in. Otherwise, we wouldn't function as social animals who can develop culture. So that's the most basic mechanism of change. And MR is certainly a very useful idea, and people have done some nice work with it. But to ignore the most, I think people change because the therapist asked them to. And a lot of the rest of it is we have to do bells and whistles to get people to do it. But right. People change because they identify their therapist as a key individual. That is somebody with wisdom and caring, high status, and they say, do it this way. And about 55% of the people will do it. And 45% require something more complicated.
I can't help, that sounds like a mediating variable to me, like an important thing that
it's how you learn to be a human being when you're a little kid. It's how we all see the culture through Western eyes versus Aboriginal people in Australia. It's incredibly important.
But a mechanism of change.
Mechanism that lets us change our inner process. So if I go to another social world I better know how to adapt to that new social group if I'm going to thrive. And that internal ability to scan my world and see what my new social group, what its values are, what it says about me, where my status is in that group, that's fundamental to me functioning as a human being in a culture. And that's Greg's person culture reality.
I want to just jump in here, Steve, and everyone else. I want to echo Andre's point that I see that as a mediator. Okay. You said it has to do with how we process our social world. It's that process. What is the process by which we process our social world that would be the equivalent of a mechanism of change or a change process? It's unpacking that, opening it up and seeing how does that actually, that concept lead to,
You're talking about like mirror neurons and all that kind of stuff?
I think ultimately it has to be biopsychosocial. I think, I mean,
you can go all the way down to I have to have ears to hear what people are saying and eyes to see it. But to me, sitting there saying we're social animals and our environment has changed and it's necessary for us to adapt to it is an essential mechanism that has to be internalized to be able to thrive and participate in any culture that we belong to.
Yeah. Can I guess only because time is growing short. I appreciate that, Steve. I mean, it's a great debate. It really is. That's what we all love. There's a lack of certainty in the, sharing ideas about those things. But I want to, because time is growing short, I want to come back, Greg, to the question you posed to Andre and I.
Yeah.
What I think is the case, and as we were doing our paper, I believe this, and I kind of believe this, is I don't think we really have identified a lot of mechanisms of change. Okay, I think we've identified mediators. The next step in research would be to unpack those mediators and see how do they lead to change. Okay, that's one thing.
Hold on, and we're never going to do that as long as we're equating mediators and mechanisms. Right. No motivation to do.
Yeah. The second thing I want to say is what complicates the problem is that we have so many mediators identified. Okay. In our paper, I indicate the different dimensions along which mechanisms of change has been studied. I mentioned a few of them. There's about 10, 15 different dimensions. Mechanisms of change as a function of disorder, as a function of theoretical perspective, as a function of stage of therapy, as a function of stage of readiness, as a function of
disorder,
biological factors. I mean, there's so many. Okay. Now, to come back, though, to the research issue and unpacking these mediators, which I really think is vital if we're really going to get at mechanisms of change / change processes, the question becomes, how do we empirically study that? Okay. And Hayes and Hoffman, and I really like their work. I mean, it's really, to me, I mean, it's just very simpatico with how I think about things. They use a lot of idiographic methodology. And I think because individual problems are so unique to each person, and the change process is going to be unique. The best way, certainly one way to capture change processes is by idiographic research, in which we, for any given patient, establish the nature of the problems and the nature of their change process. Okay, now that's all idiography, but if you read their papers, it really allows a very meticulous look into a client's process of change. Now, what do we do then with the nomothetic area? We can't just throw that out. And their solution, and this I feel like makes sense on paper, but my question will ever be done, is to collect over time, over different clients, their change processes and see if there's certain consistent ones that emerge, and maybe those lead to some nomothetic ideas. They call that idionomic. Okay, combining the idiographic and the nomothetic as a way to eventually establish at a group level identifiable change processes. Makes great sense, but realistically, Steve, in terms of your realistic constructivist view, is that really going to happen? Is that real? I mean, realistically, it's a great idea, but who is going to take all these idiographic findings and start to go through them and try to cluster them into consistent kinds of change processes? It's a great idea.
I believe they said they're going to need to rely on AI to
well, maybe that's what could do it.
But hey, I'm wondering if we should open this to audience questions.
Yeah, certainly. Right. As we're discussing this, folks, if questions emerge, either raise your hand. We'll be happy to take questions. I think Brandon at one point had a question. If he's still here, I'd welcome him to come up and take a Rick Repetti's here. Why don't we go with Rick? Go ahead, Rick, and raise your question.
Yeah, I'm not somebody with that much training in this area, but I have some. But I really want to wrap my mind around, and Greg was already pressing for this, and you've done it. I need more examples of what an actual mechanism of change means conceptually. I'm having a hard time.
So
maybe some examples.
I think there's only one example, and I think it's memory consolidation. And so basically what they show is, so a lot of us have if you're in the field, you appreciate the construct of a corrective emotional experience in contrast to like a, abstract insight, cognitive insight. But the understanding MR shows why corrective experiences in and of themselves may not work. So what they say is that there's three steps for the MR process, that the target schema, the maladaptive schema, has to be reactivated. And when that's reactivated, the person is aroused at an emotional level. That has to be presented with disconfirming evidence, right? It's like a prediction error. So if I had the experience of, when I show vulnerability, I've always been critically judged by my father, and I'm exposing myself. I'm vulnerable here with my therapist, and I have this powerful experience. If the corrective emotional experience, which is contradictory, occurs while that target schema is activated, and that process is repeated, they say that the memory is not so much of. Sorry, I'm not finishing my sentences, but so much of what happens, like in behavioral extinction, new learnings, is you're learning something new. You're forming a new memory. They say, and again, a lot of this comes from neuroscientific lab research with animals, is that when the emotion is activated, it's in a label non-fixed state, so that when confronted with disconfirming evidence, you're not replacing it, you are changing the memory. You're actually changing the schema, right? So do you see that there is a granularity of what's actually happening at the neural level in terms of memory? Because schemas are a form of memory, right? And so that to me is the only example that I see is like, oh, that's how it happens. And one of the things so Bruce Ecker, the person who first brought this into psychotherapy, he has analyzed more than a dozen cases from all different therapeutic approaches where people who did not know about MR were fulfilling the three steps and got these tremendous, enduring change. So again, it's a trans-theoretical thing, provided my understanding, though, is that if you're not working at an experiential level, that's not enough to change that activated maladaptive target schema.
One thing.
Thank you.
Yeah, one thing I will say about this. So I actually read a paper maybe a year ago on the metaphysics of mechanism. It's a very, very complicated term, and people are using this term in different ways. And indeed, I'll often throw out there this Stephen Pepper is a famous sort of philosopher, or he's got a well-known work called World Hypotheses, and argues that actually our core metaphors can be organized, one of which is mechanism, another which is form or formalism, sort of like math, seeing the world through physics, seeing the world through mathematics. Another's organicity, seeing the world as a living entity, like as if life. And another's contextual, like seeing the world as a socially constructed reality in many ways. That would be a potential example. So one of the things that's interesting about this is that when we grip the concept like mechanism, it's going to pop up depending on what your worldview is and depending on what you're thinking about in terms of what you're describing and what you're explaining. It's actually a really tricky entity to get a grip on. I'm not, my metaphors tend to be more, and frames tend to be more contextual and organismic in many ways. Bottom line is we see here the difficulties of getting a grip on what we're referring to. And I appreciate then Andre and Jack's analysis that basically says be very careful about what the referent point here is and what we're meaning.
So, I was trained. So I don't know if you know this, Stephen, but my mentor and 10-year colleague was Michael Mahoney. I was constructivism. And so he hated the word mechanism, and so, he would always talk about process, right? His book is called Human Change Processes. But so whereas principles of change are not mechanisms of change, processes of change is roughly mechanisms of change, except that the process recognizes that it's not necessarily linear, that there are feedback loops, that it is dynamic, but it still is looking at how it is and why it is that something works. So that adds to complexity. Some of these things are genuinely different constructs, principles versus mechanisms, but mechanisms and processes are roughly similar. It's just that the processes acknowledges the, again, more dynamical feedback, all that kind of stuff.
Yeah,
So let's stay with your idea that memory reconsolidation is a established psychotherapeutic technique with inherent power.
It's not a technique.
a technique.
It can be achieved by many.
It's a
It
mechanism.
is activated by various techniques
Yes.
because the point you just made is they went through 70 clinical examples and they found memory reconsolidation operating in 70 of them. So if that's true, then people who are experienced therapists should be doing that kind of stuff better.
Yes.
Now, if they aren't doing it better, that's kind of interesting, right? But let's assume they're doing it better. Then again, we'd have an experience effect. What really is going on is memory reconsolidation is a lovely idea. The idea that when you pull memory out and you put it in a context, what goes back into the memory banks is changed by the context where we reviewed it. Love the idea, makes perfect sense to me. However, that's been going on since Freud. And the fact that people are talking about doing it more consciously may end up changing stuff, but I would argue that that's part of why psychotherapy works. Just like people influence directly, just like people do some risk-taking behavior if they feel that somebody they trust is on their side. It isn't going to improve therapy if it's already part of common knowledge. And when you review somebody's history and say, you got a screwy idea about how things work, let's talk about where that came from. I've been doing group therapy for 30 years, 2 same groups. They have different people psyching in and out. I assure you that my clients in group therapy, a bunch of them are pretty darn good therapists. They identify their own and others' entrenched maladaptive behaviors, and they sit there and discuss it in a way that is very conducive to memory reconsolidation. These are untrained people in my group therapy. It's been going on, guys. And we've got to do something. Scott Miller, remember, has published a number of findings that say the effect size of psychotherapy hasn't changed in 50 years. If you accept that Scott Miller's not a wacko for arguing that, and you look at his stuff, you got to have a theory about why it hasn't changed in 50 years. We have a world full of really smart psychologists who've been writing stuff about things like mechanisms of change, memory reconsolidation for that whole 50 years. Why hasn't that improved our effect sizes? That, I think, would be a really interesting thing for us to describe. To try to explain. Now, you can say Scott Miller's crazy and the effect sizes have actually grown. I don't know. he's buddies with Bruce Wampold, who's pretty good at effect sizes. I've looked at his articles that they seem pretty convincing to me. When you're pushing for things to evolve, you need to answer why it hasn't evolved over the last 50, instead of just saying, well, this could be a cool new way for it to evolve.
Well, I would say that, again, how many decades have we been doing RCTs with treatment packages? That is not a level of granularity. And then, there's a whole group of people who have done kind of granular process research of the RCTs, and they say, oh, CBT was more effective than psychodynamic, but actually the CBT therapists who got good results were actually doing mostly psychodynamic interventions. So you've got it's not granular enough. We've got this package over here that we're comparing to a package over here with differentially trained therapists. So I just think that, yeah, I mean, I'm not surprised that we've got the dodo bird at this point, but I think if we were to actually start getting down to really studying mediators and mechanisms, I think that we might start getting useful data. But I mean, there's so much that I agree with you, Stephen, and I think I'm really glad that we've had a very pleasant adversarial collaborator, but yeah, yeah.
I'll put a plug for MR in relation. I think here's what I think the MR people would say is that actually the details of MR haven't been around for more than 20 years. I mean, they're honing in on them in particular sort of ways. We've been hitting it through corrective emotional experiences, but we haven't. But we've been hitting it sort of at common sense and very high level, relationality. They would argue that actually now we have the ingredients to home in on the key elements. We can then better our capacities to activate the memory, better our capacities to hold it, better our capacities to introduce alternative reconsolidating memories and do it quicker. That's what I think they would say. In fact, I've read papers that more or less, and they say but people don't know how to do this. And I do think if that would be the case, it would start to say, oh, well, that's a cumulative mechanistic approach to psychotherapy that's grounded in science as a possibility. Now, you obviously, I'm a big fan of what you say in relationship to really that hasn't been achieved. I think they could say it could be achieved, right? In theory, you could say that would head in that.
Hope that the next system that's
right. No, I'm just saying from their vantage point, and actually from my vantage point, it's also the case that I think I'm elucidating the general common sense, common core. And there would be potential to elucidate that with greater precision and then utilize that as a comparison to seek out things that have particular curative elements that would create a different kind of exploration. Whether we'd still change our outcomes or not in 50 years, well, I'll be dead by then. But anyway, we can have hope. Any final comments? Thank you so much for bringing your reflections. Any final comments as we begin to wrap up here? We need to make sure we get a little break.
I'll make one final comment.
Yeah.
I think the futility of pursuing, everybody says insanity is doing the same thing and expecting different results. And the critique that comes from the idea that we should look at how the therapeutic wizards operate in constructed reality instead of continually going after this medical model and different versions of specific techniques have inherent power. After 50 years, we should say enough, and we should look at whether the enlightened exorcist really has an edge, because that's a different angle that we haven't looked at. That's my closing comment.
All right. Lovely. Any, Andre, any closing comments or just?
Oh, this was fun.
I have a quick comment. I'm trying to make it quick. The whole idea of getting consensus in the area of psychotherapy, and the idea that that's going to move the field in a more paradigmatic direction. Okay, I think there's actually a big problem with that, because we're not natural sciences, and moving from a pre-paradigmatic to a paradigmatic stage in the natural sciences basically means, this is simplifying, but everybody gets on board with the understanding that's now in place and the ways the things that are studied and the ways they're studied. The problem, I think, with really trying to achieve a paradigm advancing consensus in psychotherapy is that people are just more complex than rocks. And the idea that we're going to create a singular paradigm to advance the field, I actually think is problematic. I'm trying to think of the best word. I want to say elusive, but it's more than elusive. It's a deception. Maybe that's too strong. It's just a deceptive idea. A singular paradigm to capture the complexities of human beings and how to change them and so forth, I think is just it's not really realistic. And I think paradigmatic change in psychotherapy is going to be more about accepting multiple paradigms, and a way to accept multiple paradigms. And maybe the answer is a meta-theoretical framework, but I think the idea of an overall consensus in psychotherapy is probably, I question whether that's ever really going to be achievable because of the complexity of people and so forth.
I'm going to become a plumber.
All right. Well, on that note, yeah, amen. Hey, well, thank you for bringing your wisdom to us, your reflections. It's very interesting to hear, and good antagonistic cooperation and other good things to kick around. So, all right, folks, thanks so much for contributing to the conference. Deeply appreciate it. And we have the last session coming up in about 10 minutes. I'm going to hit the restroom, and I'll see you all in a little while.
Thanks, Greg.
Take care. Yep. Thank you.
Thanks, everybody. Thanks, Tim Yang.
Thank you.